All right, guys, I am coming to you today with a special recording. There was a specific request for shock, sepsis, and meningitis. Meningitis you could actually find in the neurological module, but I did go ahead and include it on the slides just so I can say I did it and it's all in one place. But again, meningitis you will actually find in the neurological section as well. So let's talk about shock. What is shock? Well, if you think about it, when you are shocked by news or you are shocked by something crazy or outlandish or ridiculous, you stop. You like have to take a second look. So the same kind of thing happens in your body. It's a sudden drop in the flow, the perfusion, the circulation, whichever word you want to use throughout the body. And we do have four major types. We have hypovolemic shock, cardiogenic shock, vasogenic shock, and obstructive shock. And I'm going to talk a little bit about each of these, but we are going to more heavily focus on cardiogenic and one specific type of vasogenic shock. So hypovolemic, it's in the name. Hypo is low or below, and volemic is volume related. So this is a low volume state. This can be either internal or external blood or fluid loss. So a massive loss in circulating volume. Cardiogenic shock, this is one we're going to talk a little more in detail about. But again, we break down the word cardiogenic, cardio meaning heart, genic originating or coming from. So this is related to the heart. Very basically put, this is a heart pump problem. The heart is not pumping out enough blood to meet the demands of the body, which in more technical terms means there's a reduction in cardiac output. Vasogenic shock, again, we're going to talk about the different types here. More specifically, we're going to focus on septic. But again, if we break down the word, vaso and genic, vaso blood vessels, genic originating from. So the vessels become hypodilated or dilated period. So we have vasodilation that happens throughout the body, vasodilation. And so this can be difficult for the heart to pump and or circulate the blood and fluid throughout the body. So vasogenic shock becomes very important. There are three specific types. We have septic, we have anaphylactic, and we have neurogenic. And of course, our primary focus is going to be talking about sepsis because that was in the name of the module. And I apologize, the dog is barking. Okay, I apologize. I do not know exactly where I left off, but I believe it was down here at the types with septic shock, anaphylactic shock, and neurogenic shock, which according to the title of what we were going to talk about today, septic is going to be in there, but I will briefly explain anaphylactic and neurogenic as well. And then obstructive block, in the word itself, obstruct means to block, or obstructive shock means to block. So there is a physical block that lowers the ability of the heart to fill or pump out blood, which also ends up with reduced cardiac output. And so examples of obstructive shock, anything that blocks the filling or outflow of the heart, cardiac tamponade, which we talked about in the cardiac module that I just posted, tension pneumothorax, pulmonary emboli, which we're going to talk about in the respiratory module, and then compartment syndrome, which we'll end up talking about probably in the musculoskeletal section. But again, this is anything that prevents the heart from doing its job or obstructing / blocking the heart from doing its job. So let's talk a little bit more about cardiogenic shock, because this is one of the major types of shock that your NCLEX and nursing test, especially in your last semester, likes to test you on. And so this is a failure of the heart to pump adequately enough to meet the demands of the body. So in other words, the heart can pump, but not enough to meet the demands of the body. So we have lowered cardiac output or reduced cardiac output, which then in turns reduces tissue perfusion. So when I think about cardiogenic shock, I think about no perfusion to the body or low perfusion to the body. And so I want you to think about that when we get to symptoms and findings, assessment findings, whatever you want to call them, as it relates to the blood not pumping. So we have an overall goal of treatment. It relies on two basic foundations. One is to improve perfusion and thus oxygen and nutrients to the cell. And of course, that improved perfusion also means carrying away harmful waste that the body doesn't need. And then the other goal of treatment is to improve cardiac output. So our whole purpose is to improve the pump function of the heart. So again, our assessment findings, if you begin to think, like truly, truly, truly think about the heart pumping, the perfusion to the rest of the body, this should come naturally. So what we see is hypotension, which is defined as a systolic blood pressure of less than 90 millimeters of mercury, or it's 30 points below that patient's baseline. So again, that's coming from the foundation that a systolic blood pressure should normally run 120. 120 minus 30 would be 90. So anything less than that. But of course, if your patient's baseline is 140 systolic, we'd be concerned about anything less than 110. Also, oliguria. If we can't perfuse the body, we certainly aren't perfusing the kidneys. And if we're not perfusing the kidneys, we don't have adequate urine output. So it makes sense when you think about it that oliguria would be a symptom. Other assessment findings, again, if we think about poor perfusion, we have cold, clammy, pale extremities, delayed cap refill, poor pulses or weak and thready pulses. Those should all come naturally when you start to think about lack of perfusion. Tachycardia, at least initially, in some of the earlier stages of shock, you're going to see tachycardia. And we'll talk about the stages here in just a minute so you can kind of have like a what area is my patient in kind of overview. But initially, the body or the heart is going to try to pump harder, right? Because the faster they pump oxygen and nutrients out, the faster we move that blood through the body thinks that it's oxygenating better. So you will see tachycardia. And then don't forget that the brain is a part of perfusion. So if your body's not perfusion, then your brain might not be perfusing, in which case you're going to see altered mental status, decreased level of consciousness, and eventually coma if you've ignored all the other symptoms. We have some very specific treatments that happen with cardiogenic shock. And I did not add a slide here on specific treatments because they are so specific to the different types of shock. So we're actually just going to talk about cardiogenic and septic shock as it relates to treatment. So that's why they have their own separate slides here. But cardiogenic shock, very basically put, we are going to place these patients on mechanical ventilation. And the way I've always explained it to patients, family members, visitors that come into the ICU is that when the body is so stressed out, it is such in a state that it is shocked by something. The more that medicine can take over from the body, the more that body can focus on healing certain parts. So if we take over the ventilation part of this, then the body can work on the pump and fixing the pump of the body, which is all the heart. The other common treatment that we do for cardiogenic would be morphine, and that is because morphine decreases the oxygen demand of the body. It lessens the stress of the body. It reduces the number of respirations, reduces oxygen demand, and makes everything just a little bit calmer. Now, it also has the lovely side effect of pain relief. So if you were worried about pain on this patient, we have covered it with morphine. Not only have we decreased oxygen demand, but we have also improved pain or discomfort that may be associated with being in the ICU. The other thing that we commonly see in cardiogenic shock is the drug dopamine. Okay, dopamine is fabulous for cardiogenic shock. It is called a positive inotrope or positive inotropic drug. And that is because it does a lovely couple of different things. Number one, it improves blood pressure. Number two, it'll actually improve renal or kidney perfusion. And number three, it improves cardiac output. So dopamine is our go-to for cardiogenic. We have to be very careful with dopamine though, because we can actually improve the cardiac output to the point that we drive up oxygen demand. And you can actually see these patients complain of symptoms very similar to a heart attack. So chest pressure, chest heaviness, chest pain. So we have to be very careful with dopamine. The other thing that you're going to see for cardiogenic treatment is close hemodynamic monitoring. And we're going to talk about the different types of hemodynamic monitoring here in just a minute. But these patients are very closely monitored, so we know exactly what's going on with the body. Moving on to vasogenic shock, 3 separate types. We have septic, anaphylactic, and neurogenic. In septic shock, this is a massive system body-wide infection. What happens is the bacteria actually release these substances called endotoxins. These endotoxins circulate through the blood, causing extreme vasodilation, which in turn slows down or even has a pooling of the blood within blood vessels. So it eventually will lead to a pump failure, but definitely starts out with these endotoxins that cause a severe or extreme vasodilation. Anaphylactic shock, this is an allergic reaction that causes a life-threatening hypersensitivity. So this body does a exaggerated immune response to some sort of substance. Again, massive or severe vasodilation. The other thing that happens is something called increased capillary permeability, which means our capillaries, instead of like blocking large substances, actually allows those larger substances to leak out into a space. And so for anaphylaxis, this is typically the upper airway, face, tongue, mouth, throat types of swelling. So you have that permeability allows fluid to escape. It allows proteins, certain waste to extract themselves at the area of injury. The last kind of vasogenic shock is neurogenic shock. This is typically after a spinal cord injury. What happens is there is a massive or severe vasodilation. However, because the spinal reflexes, the spinal cord is damaged, the body does not have the ability to react. So a normal spinal reflexes would react to a vasodilation and cause vasoconstriction. But because the spinal cord injury, that body does not have the ability to do that reactive vasoconstriction. And so that begins, again, that pooling of the blood, decreased circulation, decreased perfusion. A lot of times in neurogenic shock, whatever level of the spinal cord, that's where you kind of see the differentiation between the shock and proper circulation. So for instance, if I had a spinal cord injury at T12, everything from my thoracic T12 area up would be nice and perfused and pink and doing all the things. But then from the level of T1 down into the lumbar and sacral regions, anything below that area would be pale, poor perfusion. So that's neurogenic shock. So back to septic shock. Again, this is a severe infection, a massive system-wide infection that can actually lead to organ dysfunction or complete failure. Sorry, I had to get some water. There are very specific diagnostic criteria before we label somebody as septic. And so the symptoms include fever because we have an infection, tachycardia, tachypnea, low blood pressure, altered mental status, edema or swelling, oliguria, decreased cap refill, poor pulses. In addition to that, we have certain lab values that happen in septic shock. And so this looks like hyperglycemia because what happens in the body is cortisol gets released. Cortisol is a type of steroid that happens under the stressful conditions of the body. And so we see hyperglycemia. We have an elevated C-reactive protein, elevated creatinine, low platelets. Matter of fact, these patients are prone to either bleeding or clotting too fast, one or the other. They're kind of at an extreme when it comes to sepsis. They may have a normal to low white blood cell count, elevated bilirubin, and classic of septic shock is lactic acidosis. So you'll see this elevation in serum lactate. Now, again, just as a review, in septic shock, endotoxins get released from bacteria. Those endotoxins then cause damage to the capillary membranes. Again, as a reminder, when capillary permeability gets damaged, it allows large particles, fluid, waste, etc., to leak out into the interstitial spaces. And so we have this massive system-wide, very systemic, everything is involved vasodilation. So what happens with this vasodilation? This vasodilation actually leads to a slowing of the circulation. That's thus in the previous slides where I said pooling of the blood, because it slows circulation almost to a stop, which results in hypotension and very low perfusion. Now, what happens when we don't have perfusion of oxygen and nutrients to the areas of the body that need it? We then have tissue death or tissue hypoxia. This also results in ventricular dilation, which means we have lowered ejection fracture from the heart. So the ventricles of the heart become dilated, and thus they have a lowered ejection fracture. Now, these patients in septic shock are at high risk for respiratory failure and acute respiratory distress syndrome. So some interventions for shock. Number one, fluid. We have to be very careful though, because our ARDS patients do not need a lot of fluid. Our ARDS patients actually need fluid restriction. But septic shock, we have fluid, either isotonic or albumin. We want volume expansion in septic shock. We tend to put them on some sort of vasopressor support. So a lot of times, like cardiogenic shock is dopamine, oftentimes septic shock would be norepinephrine. Corticosteroids are given in high doses, again, to help suppress that inflammatory response, to decrease the amount of activity that's going on in the body as it relates to the immune response. We typically have blood cultures that get ordered because we need to diagnose the specific type of bacteria that's causing the septic shock. Now, it's important to note, I forgot to add this to the slide, but the most common type of septic shock is a gram-negative bacteria, gram-negative. And so oftentimes we want to start them on vancomycin, but I caution you with that. So our general rule of thumb is that we want to do our blood work before the antibiotic. If we do the blood work first, we have a more accurate, hang on. I swear that dog only barks when I'm trying to record a session. Anyway, so it's very important that we do the blood work first, because if we give an antibiotic and then we draw blood cultures and do the blood work, there could actually be a possibility that no bacteria grows out in the blood cultures because we've already started antibiotics. So our first plan of attack is to do the blood work and cultures, and then we start the antibiotics. And the rule that we go by in the ICU is that antibiotics should be started within 1 hour after an admission of sepsis. But again, the blood work comes before the antibiotic. The other thing that we want to do, because sepsis puts patients in a hyperglycemic state, we know that wound healing doesn't happen in a hyperglycemic state. So we have a very tight control over the blood glucose of these patients. And then the other thing we do is called peptic ulcer prevention. And that's because, again, the body's stressed out, it's releasing cortisol. It also is increasing gastric secretions, which puts them at higher risk for peptic ulcers. All right, so let's talk a little bit about hemodynamics as promised. We have a couple of different numbers that are important to our shock patients in general. One is called the CVP, or central venous pressure. This is the pressure that is located within the superior vena cava and the right atrium. Basically, it measures how much pressure it takes for the blood to return to the superior vena cava and right atrium. The normal pressure levels are between 3 and 8 millimeters of mercury. Anytime we have an elevation, we think of an increased blood volume, hypervolemia, or it could be a failure of the right ventricle. The opposite to that is when it's a lowered CVP, we think about hypovolemia. So in the elevated state, anything that increases blood volume, so that would be retention of sodium in water, excess IV fluids, kidney failure or kidney injury, anything like that that causes the body to hold on to fluid. Lowered the decreased blood volume, that would be a fluid imbalance, a hemorrhage, vasodilation. So as you can imagine, the key word being here vasodilation, that CVPs are lowered. They are low in these shock systems, or shock processes, I should say. The mean arterial pressure, also known as MAP. This is the pressure on the vessel walls as the blood leaves the heart. We want a normal arterial pressure between 70 and 100 millimeters of mercury. This indicates how well cardiac output is perfusing the body. The general rule of thumb when it comes to MAPs is that it should be greater than 60. The word on the street is that if it's lower than 60, we are not getting adequate perfusion to our tissues and our organs. So the MAP should always be greater than 60 for the appropriate organ perfusion. The pulmonary wedge pressure, this measures the pressures of the right heart. We have something called, well, it is called a PALP, pulmonary artery wedge pressure. It's a balloon catheter that gets inserted into the patient only in an ICU setting. Our normal wedge pressures are between 4 and 12 millimeters of mercury. Again, when we have an increased or elevated pulmonary artery wedge pressure, that typically means a hypervolemic state, or it could be that the left ventricle has failed, or it could be mitral valve regurgitation. But again, that's that left side of the heart. And of course, in decreased, that would be hypovolemia and a reduced afterload of the heart. The last one that we'll talk about is CPP, or cerebral perfusion pressure. This is calculated by subtracting or using the formula MAP minus ICP. So you would need to know the mean arterial pressure as well as the intracranial pressure. The normal range is 70 to 100, just as with the MAP. Now, there's two key numbers here to remember with CPP. One, if it's less than 50, we're talking about tissue necrosis and tissue death. Number two, if it's less than 30, we are talking not compatible with life. So this is how well cerebral, so brain, how well the brain is being perfused. And the brain is a very important organ when it comes to perfusion. So let's talk a little bit about the stages of shock before we move into meningitis. And this is in general, this is with all the shocks, you're going to see this. Typically, there is stage 1. As you can imagine, this is the initial or start of the shock. Typical findings, just as with hypoxemia, you see that they are restless, they're agitated, they may be confused. Again, tachycardia, because the heart is starting to beat faster to compensate for what's going on. And then there's poor perfusion, so pale, cool, sluggish pulses, sluggish capillary fill. Now you'll notice here that I don't have blood pressure. Okay, blood pressure does not change until the later stages of shock. The first thing that happens is going to be tachycardia. You may see a slight elevation in respiratory rate, but you will not see a significant change in blood pressure yet. Stage 2 is called compensation, or the compensatory phase. Typically, we see that the cardiac output drops. The systolic blood pressure begins to drop. We have decreased urine output because we can't perfuse anywhere. The cerebral perfusion pressure is typically less than 70. And these patients are in a state of confusion because remember, they're not perfusing. Our cardiac output has dropped. We are not circulating enough blood. The body is attempting to compensate, but it's not doing a very good job. Stage 3, this is progressive. It states it just in the name. We get severely low blood pressure. We may even have cardiac dysrhythmias, weak, thready pulses, terrible perfusion, and there should be edema as well, especially when we talk about the vasogenic shocks, where the capillary membrane has ruptured and it has allowed the seepage of fluid and proteins into the interstitial space. This is what you see in stage 3 of shock. And then the last stage is late shock. This is severe hypotension. Instead of tachycardia, your patient has now gone to bradycardia because they're actually getting ready to enter into asystole. Multisystem organ failure, and this typically usually typically, usually, all of the words, ends in death. So as you can imagine, earlier we identify shock, the better. Okay, the outcomes improve as we identify it early on. Sometimes it's not until stage 2 that we notice it, especially when the blood pressure begins to drop, but the damage has already started. So let's move on to meningitis. Again, you'll find it here, but also in your neurological module. So what is it? Meningitis. So basically it's an inflammation or infection of the brain and spinal cord, or the meninges, if you will. It can be bacterial, viral, fungal, or protozoan in nature. Typically, it's transmitted in people that live in close living quarters. So college dorms, prisons, multifamily households, usually direct contact with the offending substance, and very commonly droplets, because you can imagine all that breathing going on, especially in the prisons, long-term care facilities, dormitories, etc. Lots of opportunity for transmission. Now, typically we use a lumbar puncture to diagnose meningitis. A sample of CSF fluid is found. Now, you should know this, not only from the neurological module, but from your nursing career, is that cerebral spinal fluid, or CSF, should be clear. Should be clear. Well, when we have meningitis, it's cloudy. We also notice that there's an increase in the amount of protein that's in the cerebral spinal fluid, an increased amount of white blood cells, and the level of glucose is decreased. So we see cloudiness, we see increased protein, increased white cells, and a decrease in glucose levels. The other thing, let me back up here for a second, that from a nursing perspective, after a lumbar puncture is complete, you want to make sure that the patients lie flat, not side lying, not prone, but supine, flat for at least 2 hours, to allow that hole to close up and prevent further leakage of cerebral spinal fluid. So assessment findings in meningitis patients include lethargic, whatever you want to call it, photophobia, so a severe problem with sensitivity to light, decreased level of consciousness. We also have what's called nuchal rigidity, where the neck is very stiff and difficult to bend. We have something called positive Koenig sign. That's a loss of ability of a patient who is lying flat to straighten their leg completely when it's flexed at the knee and hip. So that shows that there is meningeal irritability. Positive Brudzinski sign. Gotta love the name of some of these scientists. It's an involuntary flexion of the hip and knee when the neck is flexed. So the neck gets flexed up, and all of a sudden we have what's called a knee jerk reaction, where the knee begins to flex. And this is a sign of cerebral irritability. There are 2 different, very specific types of meningitis that have their own kind of classic symptoms that accompany them. One of them is meningococcal meningitis. That is accompanied by a red and macular rash, highly, highly contagious via droplet. And then we have viral meningitis, which tends to have chest and abdominal pain that accompanies, in addition to these other symptoms that you see. So how do we treat meningitis? We have some high priorities. This is not all inclusive, but this is kind of like the highlights of what an NCLEX would ask you. So of course, vital signs, those are going to be your first indication that there's a status change in your patient. Level of consciousness, intracranial pressure is very, very important. In fact, we want to reduce intracranial pressure because the meninges, the cerebral cortex, all of those things are highly irritable. You are at higher risk for seizures, or your patients are at higher risk for seizures, especially if that intracranial pressure tends to go up, because all that irritability will lead to seizure activity, as well as brain swelling if you're not careful. So these last couple of pieces, head of the bed 30 degrees, minimal stimulation, that's in order to minimize spikes in the intracranial pressure. So lights are low, volume is down, visitors are minimized, head of the bed is elevated 30 degrees. Again, this is all to help control intracranial pressure. And then, of course, depending on the meningitis, they're either going to be in contact or droplet precautions, because we want to minimize the exposure and transmission of meningitis. And so that's all I have for you. Hopefully you found some value in this as you move forward in your nursing school career and as you relate it to the NCLEX. This is just a very fast, down and dirty explanation of all of these. If you have any questions, let me know, but take care and I'll see you later.